concentration of the drug, and the toxicities would be dramatic. Or if you are a rapid metabolizer, it means that the drug will eliminate very fast and you will have no benefit from it. For targeted therapy, it involves mainly monoclonal antibodies and the small molecules nowadays that we use in clinical practice. So since all those antigens are proteins, we know that we can perform microarray analysis to see if we have upregulation or downregulation of those targets for the antibodies, and we may know if an antibody is actually working on a type of cancer or not. Also, we may have information concerning mutations which can alter these targets, and of course we may have phenomena like flip-flop, which means that the antigens can be hidden in the intracellular environment and it's not anymore available or presentable to our antibodies. What is the relevance of circulating tumor cells in clinical response in cancer? As I said before, CTCs are the progenitors. So actually they will provide all the recurrence and all the metastases. So all the information are there. That's why if we perform the study or the research, or we perform a genetic profile in circulated tumor cells and we perform it in the tissue, we may find that the CTCs will provide more close to clinical realities information instead of the primary tumor. The other one, how it's possible for a relatively small amount, as I said, to generate new metastases. Now we come to a new entity, because nowadays all the researcher in the world is working up of what we call cancer stem cell-like. Cancer stem cells are a tiny subpopulation from the primary or metastatic tumor, which actually generates all the tumor. And circulated tumor cells has been revealed that if not all of those cells, the majority of those has the features of cancer stem cells. So if you trigger to grow them, they will grow in exponential phase. We work together with a company in US called CellProgen, which provide us with cancer stem cell lines from humans, and we may start with tiny amount of cells, and in 24 hours we may have confluence of the flask almost 100%. So we are talking about something really amazing. Proceed further. So few data from our analysis. It's not so new, it's relatively old. We're talking about something which is almost 2.5 up to 3 years old. We try to collect data from clinicians, but unfortunately they are more care about the clinical work and they don't spend time to provide information about this. Anyway, hope in the near future that this will change. So here we are talking about 83 patients who are with breast cancer. All of those are in late stage of disease, stage 4, and they already perform almost all lines of therapy. And from those, 6 they had complete response after they followed therapy according to chemosensitivity profile. Partial response is were 39 patients of those. 11 of those had a stable disease, and 27 had progress of disease. As you can see from the numbers, and we consider that we are talking about breast cancer in late stage, it's pretty much good, from my point of view. Next one is prostate. Ki means Karnofsky index. I should change that to ECOG because it's much more popular now to use ECOG scale or ECOG score. 6 to 100% is a wide range. It's between 0 and 2, according to ECOG index. Still late stage of disease, and 37 patients who followed the treatment according to chemosensitivity profile. 4 of those they have complete response, 90 they have partial response, 5 they have stable disease, and 9 of those they had progress of disease. And in colon cancer, we talk about 29 patients. 2 of those, they had complete response, 12 partial, 7 stable, and 8 progress of disease. This criteria is according to ASCO criteria, which means that complete response, that there is no evidence by the compatible diagnostic of the presence of the disease. Partial response, it means that we have decrease of the tumor more than 25%. Stable disease, it means that we have plus minus 25%. And progress of the disease means that the cancer grows 25% more than the biggest diameter. So we follow that criteria, and hope in the near future clinicians will provide us with such information according to this rule. So in conclusion, chemosensitivity will point out new personalized treatment. It points out new therapy line for cancer, since we can discover new targets which can become druggable. It can predict the effect of a treatment approach, no matter if it's radio or chemotherapy. It can reduce the risk of choice of unsuccessful treatment by avoiding side effects. And it can also point out new targets which can become druggable, like HTRT, which is the human telomerase, or histone deacetylase, which is a target for epigenetics, a new field where cancer, based on how it grows and how it will change the genetic profile of it. The second service that we offer is the minimal residual disease. A few terms. Free of disease means that the patient is relieved from cancer. It means that there is no cancer cells inside his body. Remission means that there is no detectable disease by a compatible diagnostic method. Doesn't mean that we have no cancer cells. Remission means that in all body we have less than 10 to the 9th cells inside, because our discrimination ability of our compatible diagnostic is up to that limit. To go below that, we need more sensitive techniques. Relapse is the reappearance of the cancer, and MRD is the minimal residual disease. It's pretty much similar with circulating tumor cells when we were talking about solid tumors. So, as I said before, we are talking about the barrier of 10th and 9th cells.